Greetings, doctors and friends. We are from SGD 3. We will be presenting our student project about Polyhydramnion. My name is Stephen Jovi, number 161, and this is our member. There are also three chapters of our student project that are introduction, literature review, and conclusion. First thing first is the introduction. Amniotic fluid is a yellowish clear liquid that exists during pregnancy surrounding the fetus and has important roles in development progress of the fetus. Normal volume of amniotic fluid reaches its peak in 34 weeks gestation, about 800 milliliters, and in 40 weeks gestation, the volume is 600 milliliters. Polyhydramnion is an abnormal condition which there is an excess amount of amniotic fluid in pregnancy. There are some factors can cause this condition related to fetal and maternal factors. The prevalence of polyhydramnion is around 1 to 2% in all pregnancies. Polyhydramnion is also associated with various complications which increase the risk of poor pregnancy outcome. Next, this is the problem and the objective of our work. There are 9 of them, and the next is benefit of our paper.
My name is Claudia Felicia Limanda with NIM number 19025111058. Now I will explain about the definition of polyhydramnion. In normal condition, amniotic fluid is produced and reabsorbed in more or less the same amount. In polyhydramnion, however, there is a disturbance in amniotic fluid absorption, while the same amount is produced, thus making amniotic fluid accumulate in excessive amounts. It can cause swelling and increase urination, and this condition can also cause maternal and neonatal mortality and morbidity. Next, I will explain about the etiology of polyhydramnion. There are three types, mild, moderate, and severe, while the mild one is most common, and the biggest etiology for this is idiopathic. There are also other etiologies that can cause polyhydramnion, such as fetal malformation and genetic abnormality, maternal diabetes mellitus, multiple pregnancy, fetal anemia, other viral infections such as parvovirus, rubella, and cytomegalovirus, and it can also stem from urogenital disorder, neuromuscular disorder, and others. But these causes are decreasing because of the detailed ultrasound scanning and rhesus isoimmunization. That's it from me. The next will be explained by my friend. Thank you.
Hello, my name is Shanti with my student number 142. Signs and symptoms of polyhydramnion vary according to the extent of excessive amniotic fluid present. The more it is present, the more severe the condition. For example, in mild cases, polyhydramnion can even be asymptomatic. In moderate to severe cases though, usually there should be symptoms, maternal dyspnea being one of the most common. Patients could also feel tightness in the abdomen, experience swelling of the abdominal wall or lower extremities that is more severe than the normal pregnancy swellings. Signs similar to postpartum hemorrhage could also be found, and they could also experience labor difficulties such as fetal malposition or cord prolapse. Polyhydramnion might also trigger preterm labor. Thank you.
Good morning, doctor. My name is Cynthia Saraswati Sudana with the last student number 233. I'll be presenting the diagnosis. For diagnosis, one of the tools that can be used to evaluate polyhydramnion are ultrasound. Ultrasound will assess the amniotic fluid and also evaluate the fetus in pregnant women. The assessment is carried out with a maximal vertical pocket, or commonly referred to as MVP. In addition, there is also the amniotic fluid index, or AFI, which can be used to assess how severe the level of polyhydramnion suffered by the pregnant woman is. Usually, MVP can be used for twins or fetuses less than 24 weeks, while AFI is used for fetuses older than 24 weeks of gestational age. Thank you.
Hello, my name is Andre Vena with the student digit number of 101, and now I will continue explaining about the diagnosis of polyhydramnion, especially about the laboratory tests. Laboratory tests are usually performed to determine the underlying disease causing polyhydramnion. One of the most common underlying disease is maternal diabetes mellitus. So one of the factors that needs to be identified in laboratory tests is hyperglycemia. In addition, screening for congenital infections such as syphilis, IgG, IgM, and viral infections such as HIV, CMV, hepatitis, and toxoplasmosis also needs to be done. It is also possible to identify possible genetic disorders such as trisomy 13, 18, and 21, but this isn't recommended unless the case is severe polyhydramnios.
My name is Krishula Vandiapson with the last SGD number is 118. I will explain about the monitoring and management. Careful monitoring is recommended because of the increase of mortality and morbidity from polyhydramnion cases. The presentation of fetal head should be examined several times during labor to prevent a breach or transverse position. Spontaneous rupture of the membrane, it will cause acute uterine decompression with a risk of cord prolapse or placental abruption. Administration of oxytocin or prostaglandin should be given with a caution, increase the risk of atonic bleeding and amniotic fluid embolism after delivery. Thank you.
My name is Jerry and my last student number is 094. Idiopathic polyhydramnion is usually mild and doesn't appear until the middle of the third trimester, so it usually doesn't require treatment. However, other etiologies can cause polyhydramnions, which is quite severe and results in maternal respiratory distress, significant discomfort, and even preterm delivery. In certain cases, amnioreduction may be used to relieve dyspnea or maternal discomfort. Indometacin can also be used to increase water retention, which result in decreased fetal urine output, but should not be used for longer than 32 weeks because it is associated with premature closure of the ductus arteriosus. In the case of idiopathic polyhydramnions, the infant should be observed through the insertion of a nasogastric tube before the first feeding by the pediatrician to ensure that there is no tracheoesophageal fistula or esophageal atresia.
My name is Johanna Glory, my serial number is 107. I'm gonna explain about treatments used to reduce amniotic fluid. The first is amnioreduction. The most common amnioreduction is ultrasound-guided needle placement. This procedure is done by inserting a needle from ventral to the fetus. Before needle insertion, doctor will use sonographic calipers to calculate the approximate depth to which the needle should be advanced. The needle is then observed within the two-dimensional image, which is generated by the transducer as it moves into the target location. The image of ultrasound will guide the amnioreduction. In polyhydramnios, the sonogram will show needle placement of amnioreduction. Amnioreduction may be useful in singleton pregnancy with polyhydramnios. If a substantial amount of fluid has been removed, the size of uterus reduces, so it may be sufficient to change the anatomic orientation. The second treatment is prostaglandin synthase inhibitor. It acts as a tocolytic in preterm labor and has similar efficacy to terbutaline. It has infrequent maternal side effects like premature closure of the ductus arteriosus, necrotizing enterocolitis, periventricular leukomalacia. It can cross the placenta, causing oligohydramnios due to a decrease in fetal renal blood flow if used more than 48 hours. An example of prostaglandin synthase inhibitor is indometacin.
Hello, my name is Aurelius Wilbertus Novito with student number 128. I will explain the treatment of polyhydramnios, specifically Sulindac. Treatment of polyhydramnios includes the use of agents to induce amnioreduction. Sulindac is a commonly used analgesic and anti-inflammatory agent. Sulindac is commonly used as a treatment for acute or chronic infections. FDA-approved use of Sulindac includes shoulder, musculoskeletal, and arthritis pain. Despite this, Sulindac has side effects that include a decrease in amniotic fluid. This is an off-label use of Sulindac. Sulindac, a non-steroidal anti-inflammatory drug, or NSAID, works by inhibiting cyclooxygenase through selective inhibition of two receptors, COX-1 and COX-2. It is also known that NSAIDs can decrease prostaglandin synthesis and increase peak systolic flow rate, or PSV, causing contractions that can lead to tricuspid regurgitation. Compared with indomethacin, Sulindac has fewer transfer to placenta. Sulindac can also cause impaired lung maturation and limb contractures due to its amniotic fluid reducing properties. Sulindac may cause renal impairment in neonates. Sulindac is also associated with vomiting, nausea, diarrhea, constipation, and tinnitus. The use of NSAIDs is also associated with gastrointestinal diseases, with gastrointestinal ulceration being the most severe. Contraindications for use of Sulindac include hypersensitivity, cardiovascular diseases such as stroke and myocardial infarction, gastrointestinal bleeding, and patients after a coronary artery bypass graft. That's all from me. Thank you.
Okay, my name is Gabriela, student number 169. I want to tell about the delivery in polyhydramnion. So the risk of the birth with polyhydramnion can increase spontaneous rupture of the uterine membrane, premature birth, fetal malposition, and placenta prolapse and umbilical cord prolapse. These are happen because of the enlargement of the gravid uterus due to increase in amniotic fluid volume, due to decrease in ability to swallow fetal amniotic fluid, and an increase in production amniotic fluid. During birth, it is necessary to check the position of the head and the change in the position of the fetus. A retrospective case control study showed that the incidence of the cesarean section in women with polyhydramnion was higher than in women without polyhydramnion, around 31.3%.
Okay, so my name is Hara Prabhu Sakti, student number of 253, and I'll explain about the polyhydramnion's complication. So some of those complications are preterm contraction, preterm labor, premature rupturing of a membrane, sometimes followed by premature separation of the placenta, malposition of the fetus, respiratory compromise on the mother's side, prolapse of the umbilical cord, pregnancy-induced hypertension or PIH, uterine atony, stillbirth, hemorrhage, or postpartum fetal death with risk still appear even when polyhydramnios is idiopathic. The risk of polyhydramnios usually in proportion to the amount of fluid accumulated and vary with the cause.
My name is Gede Gradena with student number 193. Prognosis of polyhydramnios. Generally, the prognosis of polyhydramnios is excellent to good, with the risk of complication is tied with expansions of the uterus, higher risk with bigger expansion. The poorest prognosis of polyhydramnios have been features with small gestational age case. The prognosis of polyhydramnios is correlated directly with the underlying cause of polyhydramnios. Thank you.
My name is Brian Gervais-Delis, NIM 053. Polyhydramnion is the collection of excessive amniotic fluid during pregnancy. Fetal and maternal factors have role in this syndrome. Increased maternal and neonatal mortality and morbidity are possible consequences of polyhydramnion. To avoid complication, polyhydramnion should be identified as soon as possible using ultrasonography to estimate the amniotic fluid index. The underlying illness and the quantity of the extra amniotic fluid volume are directly associated with the severity of the symptoms and of the disorder. This is related to the uterine enlargement caused by an increase of amniotic fluid volume caused by the loss of ability to ingest fetal amniotic fluid and an increase in production. Polyhydramnion is treated with medicine that cause amnioreduction, such as prostaglandin synthase inhibitor and Sulindac. Ultrasound and AFI are two tools that can be used to evaluate polyhydramnion. Typically, lab tests are performed to determine the underlying disease that is causing polyhydramnion. Because of the increase of mortality and morbidity associated with hydropolymion, careful monitoring is advised. It is all for our presentation in regards to the student project. We thank you very much for your attention. Om Santi 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 Om.